Yes, I am. What are you going to do? Okay, did the echo go? Oh, I think the echo left.
Should be back.
Okay, I think we're back online. Sorry about that. We think it was a go-to meeting problem, so if we have any more problems, you're welcome to send us notes in the chat if you can't hear us or there's an echo or something. But if you somehow fall off the webinar altogether, go ahead and you can send me an email directly and I'll take a look because somebody else did that earlier. So thank you. Okay, so we had somebody step out of the room, Lee stepped out of the room while we were trying to fix the technology problem, so we don't want to get too deep into this, but where we had left off, or at least we recognized that we had dropped the webinar, is reviewing the quality strategy work tool, where basically this is going to be, we have a template of this up on our website under the working documents. This is just a guiding document. We haven't filled in what the measures and domains and things are, initiatives that we're going to take to put in the quality strategy. But what we're trying to capture here is existing activities that we're doing to meet the federal requirements that are listed in the waiver under Special Terms and Conditions 49. So also in there, if you would just hover over, Jill, over that first column just to show we added in, even though the three principles are in Special Terms and Conditions 49 that dictate what the quality strategy needs to look like, we've added in some additional detail there about what our statutes, our Welfare and Institutions Code and Title 22 dictate around monitoring and certification activities and reviews. So we've added a bunch of things in there, some things that actually surprised me that I hadn't seen in a while. So those are worth reviewing too. So we've listed those. This is what the Department of Aging's responsibilities are with monitoring the CBAS providers for such things as health and safety of beneficiaries, care plans, and performance with licensing requirements, certification requirements. And then the next column over is some of the processes that we have in place. So
instead of cigarette, that is much better, okay?
Okay, so we hear somebody talking. Is somebody wanting to join in? If not, then you can put your phone on mute, and then we'll hear from you when you're ready to talk. Is somebody wanting to share something in the?
Oh, you're my favorite. Thank you.
Okay, so put your phones on mute, and unless you want to be talking with us, and Jill, you'd send that note to everybody.
Is this document that you're showing on this monitor, is this available in one of those work group documents? Because the one I'm opening.
Yeah, so Burge, I think that's, is that you, Burge?
Yes, I'm sorry.
Yeah, thanks. So this document, the template for it is up on our website from the last meeting, and then we've gone ahead and filled in the first two columns. We anticipate that we'll be filling in the next two right after this meeting, probably, because we hope to be coming up with some strategies and measures. So
the version I'm opening, it's only giving me one-page document. It's not.
Okay, that's because, and that's correct, Burge. It has the three categories there that are under the waiver: the assure health and safety of beneficiaries, the individual plan of care is person-centered, and the third one is the licensing and certification requirements. So it should show that, and then the detail is here today that we're just having this conversation today.
Okay.
So you don't have that in the website version, but it's on the screen.
All right. Thank you.
And we're going to post it. So for now, we're just looking at this as an overview of what we're going to be doing to the plan itself.
Appreciate
it. Let's move on to the next document. Let's just do a quick look at the framework document just to show, again, what we're trying to do here at AG is to keep this ball moving. We want to keep you in this room working on this work group as little as possible, and we want to get done by our June meeting. And so what we're trying to capture here are work tools and tracking documents for getting this job done. So this is a strategy report framework that we drafted last meeting, and again, we've been filling in a little bit at a time. This structure reflects the structure that's in the DHCS quality plan. So we have we're just starting to put placeholders in here for items that are going to be in the actual document that we end up with come July. So we're going to have an overview where we talk about what we're doing to improve quality and why, who's been involved in this process, so we identified stakeholders, what we want to accomplish with our efforts, what questions we want to answer with our data, and who will use this information. Because ultimately, okay, here's the not so hidden agenda. I think that we want to make sure that whatever it is we come up with is important to your payers. I mean, not just for making sure that you meet the requirements, but that the managed care plans are going to find this useful in figuring out who they want to send their members to, who they want to contract with. So ultimately, the end game here is that we have demonstrated quality that proves that the providers are meeting requirements and delivering outcomes, and that the managed care plans want to buy what you're selling. Okay, so that's the overview, and then we have the focus areas. We threw out some possible domains. We've been looking at domains, and we're going to get into a document that has more of this information in it in just a minute, but we just threw out some focus areas. Again, the DHCS plan has focus areas. We have things that are guiding us, like the triple aim of the Affordable Care Act, et cetera. And so these possible domains that we're looking for here are in compliance with program requirements, reporting, training, staffing, person-centered care, participant caregiver satisfaction, and best practices. I wish Lydia were in the room, but one of the things I want to just, well, I'll wait and highlight this when I get to the next document. So those are some possible domains. Again, everything's up for discussion today. And then we just have listed, you know, how these domains and priorities relate to other initiatives that are going on federal and state level. Yeah, you want to say something?
Well, I just related to Burge's previous question where we could find this document. We have posted the initial framework on the website, but this is new information. So the relationship, for example, the relationship information is on the previous document, but we've added to it,
and we'll post it after this meeting. Okay, so it's on your screen for looking at right now. Okay, and then scrolling down, we have sort of new goals, objectives, and strategies for assuring and improving quality, which again is built into the waiver requirements, and we have some things that we already have underway. We're revising the IPC, standardizing that, and capturing better clinical and psychosocial information there, standardizing forms, processes for reporting, doing data mining and collection, oversight and monitoring activities, evidence-based practices and best practice promotion, et cetera, et cetera, et cetera. So these are all things that we anticipate that we're going to be covering in our document. I want to highlight right here at the bottom, if you scroll down to the next page, where it talks about activities and timelines. We anticipate that this will be a 5-year plan. Okay, so this is not something that's going to happen overnight. So when we put the pen to paper and actually start making commitments and establishing milestones and timelines, that this will unfold over time. We're going to start out as modestly as possible with what we can do with our resources here at CDA, what providers are able to ramp up to, and so it'll unfold over time. And then we also anticipate that we're going to need to establish a quality advisory committee of some sort, a group that will go on beyond the June meeting that will assist us with reviewing the strategy semi-annually, charting our progress, making adjustments to the plan, helping us to make adjustments to the plan, and add new federal and state measures as they're developed, and help us with implementation. So we're hopeful that we can have a few motivated people who will continue on beyond this initial effort, who will help us to make sure that we actually do this thing. Okay. So those are just some things that we flagged since the last meeting. Any thoughts? Anybody?
I just have
one
question. And it's actually a comment, but having been part of a couple of 5-year plans, you know, one of the things that's challenging is that things do evolve, and the way deliveries happen, what requirements are there. And I guess what I'm wondering is I love that you're sort of factoring that in, but I'm wondering if there are going to be ways that you can measure how you're doing given what's going on, and I don't know what quite that looks like, but I think sometimes it's hard to implement new things without being able to articulate what you're doing that is working, if that makes sense. And I don't want to make people crazy with reporting, but sometimes then if you want to ramp up a specific area to meet new requirements or new funding streams or those kinds of things, you have an argument for it process.
Right. Yeah, that's a great comment. So yeah, again, I think that just in preliminary thoughts about this piece of it, how we roll it out and make sure that we sort of hold ourselves accountable to it, that, you know, we need to think in terms of having all of those in-between steps to getting to somewhere and be able to build in sort of charting that progress and then reporting out on that, which I think is, you know, built into our website now with reporting out and being transparent about it, but making sure that we, through various channels, are sharing that with all of our stakeholders through whether it's our electronic newsletter or CBAS updates, or whether it's through reporting out at CAD's business meetings and or meetings that we have with managed care plans, that we report out on a regular basis about where we are.
Well, and where you might like to go.
And where we might like to go.
Yeah, because I do think you'll evolve.
Oh,
yes. This is going to evolve.
Yeah.
It's going to get better.
Yeah.
And probably it's going to expand. And I think those are ways that really help your effort after all the work that's been put in.
Yeah. Yeah. Definitely. Good comments. Anybody else? The subject? Okay. Anybody online? No. Thoughts? Okay. Then let's move on. Let's just bring up the document that we want to spend most of our time looking at today. And that is the possible quality improvement initiatives and measures. That. Okay, so this is a document, this is the throw it all against the wall document that I was referring to, where we have taken some of the input that we've gotten from all of you, some of the research and work that we've done in between meetings, and tried to capture some ideas. Okay, so this is the point in the program where you tell us, love it, hate it, we need to change that, this is doable, this isn't doable. This is where we're really starting to talk about what is it that we're going to build into this strategy. So what we try to do with this document by way of overview, again, there's those domains that we put up top that we're thinking of finding or of doing things to promote quality or assure quality and or developing measures. And in addition to that, what we have tried to do is to identify some that we think are already fairly achievable and identify them by the domain. And some of these things are underway. I would say also by way of overview that that we acknowledge that getting to some of the things that Oksana was talking about earlier is extremely difficult in the way of the participant outcomes piece. That it's and things like cost. So when we talk about the triple aim and where we can work on the triple aim, you know, looking at participant experience through participant satisfaction and standardized participant caregiver satisfaction may be a relatively doable thing for us. Getting at some of those additional participant outcome measures at this point, it looks a little bit farther down the road. So what you'll see here reflects things that we think are, you know, relatively doable at this point, which doesn't mean we want to take any of those other things off the table. Also in this document, what is reflected is a lot of things that have to do with the providers and our piece about assuring the provider compliance and health and safety, that they're maintaining the health and safety of participants, as well as provider structures and processes. So hi Diane, welcome. Diane Kuber-Puckett from our Peg-Taylor Center in Buchanan. Glad you made it. Sure. So what we're doing right now is we reviewed just briefly, just for your benefit, a couple of the tools that we had posted last time, and we've begun to fill in about what the document ultimately will look like and what our sort of charge is through the waiver requirements. And what we're looking at up here on the screen is a sort of, what I've been saying, sort of a throw it against the wall kind of sets of ideas of things that we have been talking about in here, that we've been, you know, gathering along the way. So these are all, we're opening it up for discussion, looking toward getting some agreement about some initiatives that we want to take, some things that will be meaningful, some possible domains, and some of these things actually reflect things that are sort of already underway. So this is all up for grabs, big discussion here today. So I was just framing this in terms of we have a number of things on this document that have to do with what's in our wheelhouse, the provider compliance and provider sort of structures and processes that that can track with quality, that can be predictive of quality, but there's not much up here right now in the way of actual participant outcomes. Okay, so what we've tried to capture again is things that various initiatives and various things that we think can be measures and things that are possibly within our reach because they're things that we might already have data on, might be things that we're already doing. So that's kind of the context for this document. So so just going through some of these things, and then I want to back out and share some things that we already do that might be helpful to this discussion. Under initiatives for oversight and monitoring, clearly the waiver STC 49 mandates that we have a quality strategy that addresses how we assure that participant health and safety is protected and how centers are meeting licensing and certification requirements. And this is what CBA does all the time. So what we've put here, just initiatives, prioritize and target monitoring of high-risk centers through use of CDA internal ranking methodology. So so we, for your information at CDA, we have processes in place right now where we have ways of sort of identifying where we have risks with providers, where we have history of significant deficient practice, the nature of that deficient practice, past complaints. There's a variety of things that I can't even tell you off the top of my head, all the things that are in the metrics. But we use that internally right now to decide how we allocate our nurses on our monitoring efforts, whether we bring a nurse onto a team when we do on-site reviews, the number of analysts that we bring onto the team, the intensity of our reviews, so that we can responsibly use our staff here at CDA to do our monitoring. So what we are sort of acknowledging in that initiative there is that we will continue to refine our methods for doing that. So so when we identify centers, again, internally for our use, we don't make this a public thing, but internally for our use, when we identify a center as being on the end of a continuum, 1 through 5, 5 being the worst, 1 being the best, and we identify a center as being a 4 or 5, they're very high risk. We have some evidence of performance problems, and we want to get out there and give it, when we go on site, to give it our best shot at oversight, and then we have expectations around our staff contacting those providers, checking in with them, getting reports from them more regularly, and just keeping a closer eye on what's going on. Those are also providers, by the way, who could use more training and more connection up with their provider organization and availing themselves of some of the opportunities that CADS provides. So that's something we already do. So I want to just give you just a quick glimpse of that because, again, I think that this translates a little bit to some of the things that we're talking about. I think we're looking, down the road to creating something more formulaic. The last time we were talking in this meeting, we were talking about the nursing home 5-star rating. I don't know how where this quality strategy is going to take us with regards to getting to a ranking, but I do want you all to see that this is some stuff that we already do and we think is important. Okay, so this is actually, this is very similar to a licensing and certification tool that's used in nursing facilities. Licensing and certification at public health uses this tool or something very close to it. It's a scope and severity grid. So basically what we do in evaluating provider sort of risk with regards to scoring deficiencies. So when we're on site and we see that there are problems, we take a look at how big and how bad it is. Okay, so the how bad it is down the left column there, that far left column, and how big it is along the top and the bottom axis there. So we look at saying there's no harm or potential for causing no more than minor negative impact in an isolated incident, in a pattern, or in a widespread level. So A, B, C are pretty much administrative kinds of problems and things that don't necessarily lead to any kind of negative outcome. The next level up for D, E, and F are minimal harm or potential for risk to health and safety, and so we look at, again, that's getting into a more significant zone, so the impacts of possible things that are going wrong that we identify. Does it happen at an individual level where there's minor harm or potential risk for harm? Does it happen at a pattern level, or is it widespread? And then the top level where there's actual harm and that compromises participant health and safety, isolated, pattern, widespread. So this is how we look at creating a score for each deficiency, so we can sort of try to remove ourselves from the opinion about what it is we've seen and identified in deficient practice when we're reviewing, and put something concrete on that. Again, this has no further implications than just helping us to do our work and allocate our resources right. So, so that's what I wanted to share with you today, just to sort of to let you know that as far as what we anticipate doing and putting into the quality strategy, that we want to do is we want to get more oriented to concrete measures that help us to make decisions about where we're going with provider oversight and how well providers are doing with regards to those measures. Does anybody have anything to say about that? I see some cocked heads and looks in the room. Yeah, Diane.
Well, I was thinking about the relationship of this to what you were just talking about. For some providers, it's a lack of knowledge or training. Mm-hmm. And I was curious about what would happen if you threw that into the mix, because, I mean, something could be potentially very harmful,
right?
Not intentional, based on lack of knowledge. Mm-hmm. And it would be interesting to get a sense over time of, kind of how much intentional harm versus unintentional harm is taking place.
Yeah, so and I'd be interested in hearing more about how we might get to that, but yeah. Yeah,
and kind of along the same lines, as I was looking at this, I also wondered about whoever's providing the oversight that's rating these facilities. I'm wondering, what are we doing to ensure that they have the tools they need to understand what they're saying?
Yeah,
and absolutely. Because having been on that side of it, I see sometimes that people don't know what they're saying as a safety issue, for instance.
And it actually goes to something that I didn't put on this, if we can jump back out to the document, that I didn't put on, but that I have thought of for a number of years in terms of our oversight and monitoring here at CBA. We do a lot of in-servicing, but absolutely there's variation among our survey staff, and people have different interpretation and different skill sets. We try to sort of standardize things, but it's very true. And so how do we get at having people have sort of uniform ways of approaching things? And part of why we're doing this scoring is because for years we've had this problem. It's like our survey staff will come back and say, the center is in real trouble. They have all kinds of problems, and then we have like 4 deficiencies that are cited, and they're not even in significant areas. So if they have problems, what's the nature of it if you're not finding? Or on the contrary, we'll have surveyors come back from a review where they say, oh, the center is great, but then they'll have 15. So in part, we're trying to find ways of developing systems for identifying and accurately, consistently, capturing what it is that our folks are finding. So this is all very, we're taking baby steps, and I think one of the steps that I would like us to flag, if you would, Jill, just if you put it in another color, is just to add something that is a flag for us about. I'd like to see our staff, as we train them, to go out and do ride-alongs at centers, to find ways to be at centers where they're not there in a compliance mode, but they're there to learn and to do side-by-side sort of along and do some sort of center-based learning. Because we do in-service and we do orient and train, but it's we can improve on that.
Can I ask a question?
Just right in there, just put center-based training for CBA staff.
And this may be irrelevant given because all the stuff that's going on is, I guess my thought is I'm less worried about CBA staff than I am about whether the rating system might be not congruent with any other oversight group that's doing work. Like, I don't know, if licensing also is going to come in and do some kind of an oversight. And my thought was, is it also in sync with what they're looking at so people don't get bombarded with conflicting, perhaps, messages? Because I think, it's my opinion that you all do a pretty good job of doing the training and you have a core staff that you consistently see. And are we making sure that that fits with? I'm just thinking about if I'm the provider, how that.
It's a really good point, and I think part of the benefit of having this collaboratively developed plan that we have consensus around and that we publish, that takes us in the direction. Yeah, absolutely. Yeah, Lois.
And I think the other piece of that also is to eventually address some of the inconsistencies in the regulations. We've talked before about the regulations need to be updated because there are certainly inconsistencies.
You want to flag that too, Jill, if you would, just put this, sorry, I know you have multiple jobs here, but just that we know that regulatory and statutory reform is part of our challenge for the future. Yeah, Diane.
Yeah, and relative to that, I think one of the most important needs right now is to be able to have sort of an endpoint, core endpoint set of requirements where one thing has superseded another. I know I've said this before, and I know it's a lot of work, but we can try and comply completely with the regs, but if something's been, superseded by the SOPs, then what it does is waste time, basically, and time is really valuable when it comes to achieving quality. And so the more we can simplify what the standards actually are so people can clearly see what today's standards are, they can aim directly at those standards and not.
And I think you'll see that in some of the ideas we've thrown against the wall here today. So, yeah, absolutely. Yeah, question.
Min Cole had a question. It says, where can we add leadership development in the system? Such as the AIT program in SNF, or even the licensing for administrators and program directors.
Great.
So I believe that we need true leaders in ADHD.
Good comment, Min, and you'll see that on the wall here when we scroll down to it. So again, remember, this document at this point, because we're the only ones who've had our hands on it, it looks a lot like providers, sort of structures, processes, preparedness, and quality. So we know there's other measures to put in there, but this is what this document focuses on for now. So any other ideas? Yeah, throw them out here and we'll put some placeholders. Okay, so that's oversight and monitoring. Lots of work we can continue to do here at CBA to standardize and to get to prioritize things correctly. So on processes is another sort of category for initiatives. Actually, could you scroll back up because I think I might have missed one. Oh yeah, I put a placeholder there for communication and collaboration between CBA and the managed care plans, because obviously they're our partners in making sure that we have providers who are well prepared, who know what the plans expect of them, the plan rules. They're delivering care to their beneficiaries. They're getting some feedback from the managed care plans about care coordination, et cetera. So I just put a placeholder flag there to make sure that we know that the managed care plans and CBA, we already have processes in place where we share information, but there's a lot more to be done in that area. Okay, so going down to standardization of forms and processes. So we're revising the IPC. This is a big sort of endeavor that we're all engaged in, and we think that that's going to drive some better quality. What it is we're capturing in making sure that we are driving more participation by the beneficiaries, so that their needs, preferences, choices are reflected and are person-centered. So that's already underway. Under number 2 there, develop list of recommended screening/assessment tools for centers to voluntarily adopt. And we put that as a domain best practice. So this is something, again, that we've all been talking about for a long time, that there are challenges with mandating certain screening tools and certain assessment forms, but there are also benefits to having standardization. So we were trying to wrap our minds around how might we do this, sort of make this a agreed upon quality standard, and that the providers could choose from a menu of standard tools and commit to using those and actually implement them, and then get some kind of a sort of a quality point, if you will, for adopting those. So, and this goes to Diane and Lydia, when you were just coming into the room, I just want to emphasize that what we were talking about before you got here was the 5-year concept of this strategy plan and the need to have a quality advisory committee or group that goes beyond this, this initial development, so that we make sure that we're making adjustments and making decisions about things like this. So if this is something that we all embrace and we say, hey, this is a great thing to have, then how do we get to what the menu of options is, And so we think that there are going to be work group activities beyond this figure. Okay, so what do y'all think of that? The idea that we have a list of, and we don't mandate it, but we say here are the ones that we believe that inform CBAS. CBAS, was that you're not sure, or were you just shaking?
No, I'm just shaking.
Okay, so this is what we think is a good group of assessment tools that providers should embrace, and that centers that adopt these tools, there's some kind of a quality that goes with that. Yeah, Lois.
I think perhaps in addition to options would be some flexibility in the use for specific centers. Every center has slightly different needs.
Right.
And as long as there was some flexibility in
right.
adjusting.
And I think that's what we were intended. Maybe the verbiage isn't clear enough there, but the idea that there might be 2 or 3 tools for screening for, say, depression or for cognitive status, et cetera. So, yeah.
Well, I would just say, because we have a whole toolbox of tools that we've been using for our community-based health plan. You have to find public domain tools.
Yes.
You have to be sure that they're able to measure. If it's a screening tool, it's a screening tool like the KJ8, but if you're using it to also measure change over time, you have to be sure it's sensitive enough to do that. Right. I mean, there's just all these factors. So, yeah, cultural, we had one tool that wasn't working for non-English speaking participants, for example, so we're giving people an option of another tool that works a little bit better. So over the next few months, I'll be working to look at our whole data set to see of those tools in our toolbox, which ones seem to have sensitivity, which ones maybe we don't want to use anymore, or which ones. So we've done, I just want to say we've done a lot of work on this already. Yeah. And I think, trying to align what we might choose for standardization, I do think the field is ready for that. We need to be attentive to all the other activities, especially at the federal level that are going on. NCQA working on things, this impact law, federal law that is looking at domains across all, from hospitals to home community, and they've come up with a list of areas they want to measure for quality. So I'm saying to Denise, we need like a big grant and staff support to really get into this. It is not as easy as it sounds on the surface.
And Larry, there might be an argument for this being an initiative if we like the idea of it. We put it in there and it's a as resources allow, or maybe it's a 2 or 3 year out kind of thing. But I think, we were just thinking.
Start with something.
Yeah, to start with something. And exactly. And again, I think just to inform this discussion even further, I think it's our desire to find a way to maybe not come up with a ranking or a 5-star or anything, but to be able to identify, say, on our CDA website by provider who are meeting some additional quality standards, not just meeting the standard requirements for participating in the program. But this has been a great frustration of my career for the last 20 however many years, is that we get ground down, doing our oversight work and dealing with, sort of mediocrity and not such great performance. But we're only talking about what we're only able to work with, do they meet minimum standards? So we want to talk about the provider not only meets the minimum standards, but in addition to that, they've taken on all these additional measures and said that we can say yes to their doing that, and we can publish that and make that information available. So it's a way of giving, before you got in the room again, Larry and Lily, we were talking about that we want this to add up to something, as in your payers want to see this and value this, and this becomes meaningful for how they refer their members, how they work with you. So,
just to comment on that, I think that it's so great to hear that. I think that's outstanding. And, consumers, frankly, don't know what they're looking for when they first go to an adult day program or a skilled nursing facility or any other thing. And having something that says, here's some quality measures that we look for. And this facility is also doing this, this, and this, or has language in Spanish or Chinese or whatever. Those kinds of things are, whether or not the fact that they're meeting minimum standards is fantastic, but I love that you're looking at how we sort of elevate this and say, if I know nothing about this, how do I even choose? And at least you're giving me some measures that I can look at and say, oh, I get that, right? If I'm completely out of that
And we have a lot of this information, so we know that this is already, again, on our radar, that we need to make more of this information available. So, and you'll see that on our list when we scroll down. So I'm glad to press.
And I just want to share with those who aren't on the CADS quality work group, there has been a lot of work done already on designing metrics that translate to a number so you can do comparisons. And one of the things, again, you know, everything seems easy on the surface, but that we really spent a lot of time on was talking about staffing ratios. And what's the minimum? How do you measure if someone's exceeding the minimum? And coming up with a common way to do that across all centers. So we've come up with a way to do that. We've come up with actually 3 different ways to do it that use the same numbers but use a different numerator and denominator. So you could slice it and dice it different ways. So we tested it. Now we have to pause because of other things going on. But my point being that, again, we might want to pick, you know, just 1 or 2 or 3 things. Dig in, try it, adapt, adjust as we need to. But if we can just begin that process and get people used to that idea, that that's how you measure.
And I'd say even
be fantastic.
Before that, for us, comes this concept of we have a lot of these things either available to us now or readily available. You'll see one here really quick. And so we want to just find a way before we even get to some other numbering or ranking or gold starring, that we can just make this information more readily available. So, we'll hold that thought and you'll see some other things. Okay, so that's idea number 2 under standardization. Number 3,
I just wanted to make a quick comment about tools, assessments, and tools. Within the scope of CADS, you know, we spend a lot of time, dedicated time to tool development. And Lydia just made a comment, and I completely agree, you know, how difficult it is because, you know, you have to make sure that you comply with all the standards, national standards and so forth. I think it's much more difficult for providers, you know, to come up with their own tools. And so you can imagine, you know, first of all, the variety of tools available out there. And so my thinking is more, you know, we have to spend more efforts to try to develop, you know, centralized, you know, tool systems.
I agree. And again, being sensitive to this, we don't want to mandate a bunch of these things, but we want to produce some more job aids, some more materials that will help you to do what we think is going to be better work, and, you know, work with you on creating what those are. So it's just, you know, definitely mindful of that. It's easier for us to sort of as a group do it. Yeah, Lynn.
And I think that you were inferring this, but to learn from the providers, what tools are they using that they find helpful for the populations they're serving? So really from the ground up to get the experience of that, as well as looking at other programs like the Senior Services Program, MSSP. They require that providers use screening tools, but they allow the providers to choose among several options within different domains. And we can learn from those providers what has worked for certain populations based on diagnosis, cultural, language. So I mean, I think that it takes a lot of time, but it's worth doing and making sure that nothing is prescribed that doesn't fit.
Okay, let's move on. Do we have anybody online who has anything?
No.
Okay. Anybody who wants to share anything at this point who's on the webinar? Okay, feel free to type in anytime. So let's go to number 3. So this goes, building on this theme, we say a possible initiative here is to develop discipline-specific or program component-specific checklists for centers, again, this is the job aid, to use to self-assess compliance with laws, regulations, waiver requirements. And I gave some examples here because we actually have some staff here at CBAS who have been chomping at the bit to develop these kinds of things and get them implemented. Again, not mandating their use, but making tools and job aids available to providers to understand. And say our nurses have developed a medications checklist here at CBA. and to look at each of the program components, disciplines, even a documentation checklist. Again, some tools that we can put in the hands of providers that they can voluntarily use, and we would, of course, sort of validate their use and then give sort of quality point for that as well. Any thoughts on that? And again, I would imagine this would be another one of those items that a continuing work group could work on developing. And we have several that we've already actually started to kick around. Again, a best practice. Number 4, develop uniform history and physical and update form per the Welfare Institutions Code. So this is when we were looking at our IPC, actually just as recently as yesterday, we threw this one on here because in the Welfare Institutions Code for ADHD, CBAS, there was language put in with Senate Bill 1755 many years ago that we were going to agree upon a standardized history and physical form and a standardized history and physical update form that would be part of the IPC. It's actually still in our IPC language, and it's in the statute. We never did it. We never reached, well, we worked on it, but we never reached agreement, and I think that this is an issue worth revisiting. Do we want to standardize what that history and physical form looks like once and for all? Otherwise, I think we need to take it out of the statute because we're not going to implement it. So my view is that it's a good thing to have standardized as well as the update form and have processes in place that support the IPC, which are not in place right now.
So again, for a point of information, CADS, under the leadership of Don Myers-Kirky, developed a standardized H&P form and made it available to our members on a voluntary basis. I don't know how many are using it. It could use some updating now.
Yeah.
And we never worked on the update form. I don't even know if we need one or not, but I think it's a worthy effort to revisit that.
And again, Lydia, put it up there because it's listed in the statute. The update form, I think the original idea was that it was too burdensome to physicians and providers to send a huge form each time, so that we would have some kind of a truncated version of that form. But yeah, I'm aware that you guys developed that, and we had gotten semi deep into our negotiations about that form, and DHCS and CBA and the providers couldn't all agree on it. So it's great that some people have implemented that, but I think it's time to dust that off and look at updating it and standardizing it. It is LIA. Okay? And jump in and stop me any old time. Okay, so number 5 there under standardizing, develop standard participation agreement form that conforms to regulations and substantiates person-centered planning processes. This has been on my list for a long time. And not everybody agrees with that one. At the very least, I would suggest that it's worth us developing that template and letting providers adopt it, add on to it, do whatever they want to it to make it their own, but to keep a basic subset of components in their form.
I know we had some discussion about this between you and Nate about the fact there was a participation agreement form which we continue to use today. As far as we knew, it was always required that we use at enrollment. And are you thinking of building from that?
Yeah. So it was in the old staff procedure the procedure manual, and I think at that time it was a sample, and it was recommended as a sample, and providers have adopted it. No? I have to go back and look at it. You remember all those better than me. But yeah. So yeah. I mean, I think we have a template, and it's adding on now the new person-centered requirements. So I don't think it's a big reach for us to get to a standardized form.
Right, and a part of what it says is it's very basic. It essentially says that their care plan has been explained and discussed with them.
Yeah.
And if we were to add to the assessment processes documentation, person-centered aspect, that form itself could still stay much as it is because it's pretty user-friendly to the participants.
Right.
It enables a good discussion, I think, between the social workers and them about their care plan without being overwhelming.
Yeah, and again, when I say to develop something standardized, I'm not meaning let's do something elaborate and huge. I think I'm just like trying to get to, we want to in many ways teach to the testing providers, especially as we're getting new providers. They need to know what are the minimum thresholds expected of them. Days per week of services is listed in the regs, listed in the law about what has to be in the participation agreement. I think it's in that old sample. There's certain things like that we want to just have uniform and have everybody understand.
Yeah.
And that old provider manual that we're talking about that Diane is referencing, I don't even know if you guys have a copy of that. That has relatively new compared to Diane's site. It's something that has sort of gone out of print. We, for lack of resources and abilities, we have not reprinted or updated any of those letters probably since 1995 or 6. So
and I think you're referring to the new improved older adult manual.
Right. Yeah,
The blue
exactly.
covered one, right?
So maybe updating that manual would be something to put in the quality strategy. I don't know. No, that's going to
We should dust that up.
that's going
and see
to live
what's in
beyond
there.
my tenure, I hope. So that's a big project. You have never seen it, yeah.
It's good.
I was just going to reinforce, any form that we're looking at or process, it always now has to be with the lens of the HCB services
absolutely.
rule and the settings requirements and person-centered planning.
Yes.
So it's just everything we do has to have that.
Yeah, it has to be updated, brought up to date. And we have a lot of good old tools. Again, it's a matter of dusting them off and training to them and reestablishing. Okay, so moving on. Now we're getting into the category of improving training and competencies. So this is an area, actually I wish, Ruth stepped out of the room, so let's skip over this one until Ruth gets back, because I want her to, can we go down to promotion of evidence-based program? Actually, let's go to data collection. I want to wait for Ruth on this one. So let's talk about data collection, analysis, and sharing as an area where we're going to do some things, we think, in this quality strategy. So increasing transparency by posting more center demographic information and statistics regarding deficient practice on the CDA website. So the demographic information, we were talking about that. So what do we know about the centers? What languages are spoken? What hours of service do they offer? Do they offer extended hours of service, or is it a program that's open from 9 to 1? That's it. These are really important pieces of information that tell prospective participants what's going on, and caregivers, to the managed care partners, et cetera. It's just basic information that we have a lot of access to here at CDA that we just don't put on the website. So this is a process. Here to my left is busy working on, as is Adam, working on our CBAS data portal, where we're going to have provider interface, and we're getting close on that. We're going to move forward with more enhancement of our database so that we can actually have if I step out one, where we can have, we have a front end and a back end where we have data comes off of our database and loads our website. Things that Adam does manually right now in our shop, so that we make a lot of data available on our dashboard website, but that we have the capacity for, as we make changes to, say, a provider's center's hours of operation, that it can load up and update the website where we have accurate information. So we're talking about data initiatives and where we can share more information about what we already know about centers and possibly begin to bring some more information in. Yeah, Diane.
I think that'd be really helpful. And as an entry point for consumers, I was just reviewing the description of the Adult Day Health Care Service and CBAS on the CDA website. And I think it's probably a really good time, if you're going to start putting more of this kind of information on the site, for an update of that information, and to convert that into something that is more consumer friendly and explanatory about what we really do in our programs. Because it's a very technical description right now, and it's really based in history at the moment.
Yeah, it does have the history.
You know what I'm talking
about. Let me ask you, Diane, because there's two places we have fiscal fact sheets and narratives that we keep for all of our CDA programs that we're mandated to do under the California Act. And we just updated those, and that's a very technical one. But then the one on our CBAS landing page, you're also finding to be too technical, or
that's where I was going.
Okay, that one. Okay. Yeah. So yeah, we'll take a look at that and give it some dust off the narrative. Yeah.
And I've looked a number of times at how to try to find, as a consumer, what adult day health care does.
Right.
And how to sort out what CBAS is versus what adult day health care is. And I think it's really pretty impenetrable right now for somebody who doesn't already have understand it.
Yeah, it's pretty much designed for, it's not designed for participants, it's more for providers and managed care advocates. Okay, so we'll do that, and can we put your name next to helping us with review?
Absolutely.
That'd be great. Thank you. Thank you, Dan. Okay, so the on-site survey results. So on our CDA website right now, this is something that we have been promising for some time. Instead of publishing actual copies of our reports, which we believe are not very user-friendly and accessible to anybody, is what we would like to do is to break down a couple of data fields that we right now on our CBAS dashboard that we aggregate by statewide. So, for example, end of every fiscal year, we put survey statistics for the year where we identify number of overall statewide health and safety level deficiencies and repeat deficiencies by center. So we total it all up. But we believe that we need to get to a center by center rating like that. And that part of the foundation that we were trying to build before we did that was to put that scoring of each deficiency in place so that we would have something sort of standardized. So health and safety level repeat deficiencies. Health and safety level, the break is that we have worked with our legal department on, based on our regulatory authorities, saying that is if it went to an E level in that graphic that we just showed or above, we're designating it as a health and safety kind of finding. So in other words, we identified a scope and severity that's significant enough that it's more than an isolated incident and that there are ramifications for participant health and safety risk. So right now we report those, again, aggregated statewide, but we don't have it on a center-by-center basis. So we want to do that. Spin holes. What do you think? Yes? Yeah?
Absolutely.
Okay, absolutely.
I think it's a great idea.
All right. Okay. So let's. Okay, so this is continuing along in the data collection, etc. Identifying centers that submit timely and accurate required reports. Right now, again, we do this internally because we have providers giving us monthly statistical reports that are required by regulation, incident reports, discharge reports, participant characteristics reports. All of these things sort of are important reporting and tracking documents for us, but they also demonstrate a certain amount of administrative capacity. The capacity to be organized, to be sharing your data with us on the required timeframes, and you cannot believe what we go through in the way of gymnastics trying to get some providers to report to us. So we believe this is definitely a lever to pull, if nothing else, to get providers more on board with giving us complete, accurate, timely reports. So right now we don't score people, do we? But we track who's not reporting on time, and I think we could very easily get to some kind of a threshold. Again, with an advisory group, we agree on if a provider is late more than 5 times, let's say, in 1 year with their MSSRs, or if they're late every time with their participant characteristics, whatever those thresholds may be, that we have them have a special or in the reverse. If they're on time all the time, we have that be a quality sort of point. Yeah, Ruth.
And this is just a question of ignorance. I know we talked about how the different programs track data in their systems, and vis-a-vis with the health plans, and that they have different systems. But do the programs that you're evaluating have a way to equally gather the data and use an identical system so you can compare across the same system of measurement that they could just put into? I mean, I just didn't know if they have a data system. You know, like if I have a grant from the county, I have to enter my data in the county's data system. It doesn't really fit with my system. I'm wondering, do they have a tracking system that they all equally put their information into, that's evenly easy to access? And this is,
so systems know, if I'm understanding you correctly, but forms and reports standardized, yes. All of those forms and reports that we're talking about, there are standard reports, and there are standard expectations about when the providers are supposed to give them to us. So the monthly statistical summary reports, it asks for certain data fields about enrolled participants, average daily attendance, participants discharged, newly determined eligible, yada, yada, yada. They have to give them to us by the 10th of the month.
No, I get that. Okay. I get that you have forms. What I'm asking is do they have equal ability to gather that data? Like, do they have a computer system that goes in, or do they manually say, okay, we had 15 people today, and yesterday we had 12, and I truly just didn't know.
But most centers, but it's different. Some people do still do things manually.
Yeah.
And we don't all use the same computer system for our participant records.
Right.
We do all use the same IPC.
Right.
So that IPC is the same information for every center.
Okay.
But Louis, I believe that all the existing software systems that centers are using, they all accommodate those standard reports. So, I mean, there are 3 or 4 different software packages, and they all have provision for MSSR report and
Okay, so they have access
Yes.
to the ability to track
Yes, right,
evenly and equally.
Yes, but let me add on to what Mark is saying though, and I'm going to look at you, Adam, and put you on the spot. We have done surveys of our CBAS providers to determine how many of them are actually using the software vendors for packages and how many are doing things manually. And I don't know what the breakdown is. Do you know off the top of your head?
It's a little more than 2/3 are doing things software providers.
Okay.
So we still have a third doing manual.
So yeah, so we have some folks that are still out there with the with the abacus and stuff. Yeah, yeah.
Right, it's not necessarily an abacus, though.
Yeah.
And there may be reasons for not using the pathway that the software vendor provides. And so what I would ultimately like to see, though, I know we'll get into more discussion about this, but with participant characteristics, especially getting the detail into that does take time at this point to have it all be accurate.
Yes. Oh, yeah.
And I know I had made this request before, but I'd like to request again that the time frame be changed on submission of that.
Okay.
Because in order for that to be prepared accurately with everything else going on, to submit it in January without a little bit of extra wiggle room in there is very difficult for our program directors.
So even that, because we did extend it from the 10th of the month, because we were trying to keep it aligned with the MSSR, to the 31st. So even having the full month, it's still.
Yeah, there's a lot going on.
Okay. So extending that period. Okay. So we'll talk to you further about that.
Yeah, and what it might be is just it goes by this time, but then you have an understanding that there's a late payment period.
Yeah, we'll have to talk to you about it because we have some challenges where we get too far past the deadline and then the data in people's systems gets updated and we don't get a point in time. Yeah. So we'll talk to you further about that. Okay, could you also put a placeholder, Jill, here for that we need to, just for participant characteristics report update to reflect some of these things just as a placeholder. Okay, then the last item there, number 3, this goes to, again, more tracking. This is data that we already have that we can expand out and make it look a little bit make it a little bit bigger. But the track ratio of monthly hours of therapy service provided by professional therapy staff to hours provided by program aides. Again, not looking at necessarily a numerator denominator that translates to a score, but we can report out right now if we felt like it was worthwhile, and we can capture this better. What's happening with regards to ratios? So, for example, the minimum standards for the number of therapy hours are set in regulation based on average daily attendance, and there's no specificity around how many of those hours need to be professional therapy hours, right? And there's good reason for that. This was developed, the maintenance program concept was I think, built into the statute after the regs to accommodate or to address the fact that we have a lot of people who don't need restorative therapies, they don't need professional level staffing. However, we also have providers who provide a very, very low level of professional level care. It kind of goes to what Lydia was mentioning earlier about exceeding the staffing ratios, for example. So we were thinking that it might be worth us, right now we already have this about the number of hours as a percentage of the overall therapy hour requirement that is being provided by professionals. So, for example, if you take a center that is required to provide 200 hours of therapy services every month, and I think that means that they have 40 and 80 something like that. They have to provide 200 hours, and 20 of those hours are provided by the OTPT mental health consultant. They are providing 10% of their hours from professional level staff versus program aide staff. We have those numbers right now. So is that a valuable thing to share? I will tell you from a compliance point of view, we think it is, because because what we see oftentimes is providers who have required number of hours is 600, and we have them providing, 6 of those hours from professional level staff. But yes, at 1%, that's not even enough time. At 6 hours isn't even enough time to do all of the required minimum assessments each month or new enrollments. And so these are problems that we have in oversight of the programs, but I also think that it kind of tracks with quality, that you have professional level staff that are available a higher percentage of the time. What that threshold is, I don't know, but I think that there's a big difference between a provider that's meeting their therapy hour requirements 20% with professional staff versus 2%. So what do you guys think?
Did we include I don't remember the therapy into the ratios?
Yeah, I think we took a stab at that.
Okay.
Yeah, so the ratio structure that we were brainstorming, in the CATS group, that, I think we do have it, we can get this data, and share it with everybody. I believe we did develop a ratio for therapy.
Meaning a threshold where you think it's
right. I don't remember the formula, right? But I have to go back and refresh it.
Right.
Yeah, we'll be happy to share our work.
Yeah.
We just haven't tested that yet. We tested the others.
The nursing.
We tested nursing,
and
social work, I think.
And CNAs and social work.
Yeah,
right.
So we just haven't tested it yet, but we have an approach to it. So and I'd be happy to share all that.
Yeah, and I know you guys were doing some things in this area, but again, I was thinking of how we can just reflect descriptively what we have right now. So even to just be able to imagine a day where you could click onto our website and look at each center, and you could look at the percentage of their therapy hour requirements that are met with professional therapists. It's 1% or it's 20%, or you know what I mean. So it's descriptive. It's not really a threshold where we say this is quality versus this isn't, but it certainly stratifies the providers and tells members of the community, caregivers, plans, what's going on.
Yeah, though, I think the danger in that, or the caution, I won't say danger, the caution in it would be that because we do have such a variety of programs who have different target populations, there has to be a context set, because you may have a lot of maintenance therapy hours because you're serving primarily behavioral health, for example. You know that. I'm just saying it for the whole group.
Right.
And so I think there's value to that, but we have to always set the context, because it doesn't necessarily mean because you're low therapy hours, you're poor quality.
And the other thing I was thinking relative to that is that, small programs versus programs serving, larger numbers of people, just naturally over time, you're going to have more people go on to maintenance therapy and sustain them.
Sure.
So you might really have a disproportionate, we might do 100% of our hours with our skilled therapists, but a larger program may need to bring in more maintenance therapy.
Sure, and I, again, because I know how we have we have this information, we don't have actual data sets with it right now, but we would be able to, we could stratify it any way you want. We could look at OT, PT, mental health consultants, so you can take into consideration the population that are served. We could combine them all, we could take each of them separately, we could take it as a factor of you're a center that serves 200 people versus you're a center that serves 100. So we can slice and dice it any way we want. But again, it's like the question is, do we think it's possibly a meaningful measure to go after, or at least a descriptive?
Well, I don't know if you have the staff bandwidth to do this. I look over at Adam.
Yeah.
He left. But, just like we did in our little quality work group, if you have the data, you could try some different calculations, and then you guys already have your grid of scoring. Yeah. So you have your high risk to your high quality centers, right? So then you could test it out and just apply it to those centers. Take a handful from fives, a handful from ones, one in the middle, and just try it.
Yeah, and again, just so yes, I hear you.
Yeah,
and right now, all of these things we're running sort of off database because we're in the process spreadsheets and things. But with regards to the information about monthly therapy hours. We don't even have this tracked and aggregated. And we collect it as part of our survey review, but we haven't built it into anything that translates to anything beyond that particular survey. So again, it's a process. We would need some kind of a process where we're roll it all up and we have it all in electronic format. So we don't have that now. It's all sort of doable because we're trying to think about building on the processes that we already have. We already asked for this data. We just don't build it into anything yet.
And is our intent, and this is totally, again, an ignorance question, with this data, once we start gathering it and putting it onto a website, is the intent of the website to be, for those of us who are in the field who are looking up, okay, I need to send somebody to a facility that serves a lot of folks with DD versus Alzheimer's disease, let's just say, because those are very different. Or are we talking about a consumer-friendly, not a lot of jargony stuff, not a lot of acronyms that I might understand, but my clients' family members won't. And so are we being really clear on how and who to whom we're aiming this? Because I do think what we give out, those two questions are really different to me.
It's really important, Ruth, and I think it's so preliminary to that, I mean, you're just informing our thinking about it, but I think, you know, the website can serve all of those populations, but I think, you know, in how we translate this information to the managed care plans, even to say how they talk to members about what's going on at a particular site, you know. So you need intensive therapies, go to Mark's site. They've got lots of PT and OT hours, and you know, so that's I think the way that it could actually translate in actual use. But yeah,
well, and with that in mind, right? If I get information from Lydia on the facilities in my area, and I'm a consumer, I want to look them up and say which one has 4 stars.
Yeah.
Or exactly. You know, what do people say? Well, they say my life, or this place sucked. You know, and I'm not saying that that's what we want, but what I'm saying is let's, when we start talking about website development, crazy if we're not really, really clear of if we're going to build this out, and it might be in layers. Maybe professionals is who we send it to. We set it up for first, and then we build it out to be more consumer friendly.
Or then we have 2 different paths. I mean, a lot of, I think that your website, actually for Medi-Cal, we have the providers versus the beneficiaries.
Multiple, that's right.
Multiple sections.
Right.
Yeah. Good considerations, Ruth. Okay. Yeah, Lois.
Exactly. Well, you know, program level, I think there really needs to be, at some level, I mean, it's, you know, some from CADS, from CDA, wherever, but there needs to be some really good training so that the reporting of the data is consistent. I mean, this is going back, you know, some months what we're talking about, but as you're talking, I'm thinking of things like we end up having questions every time we're filling out the participant characteristics form. You know, every time the therapist comes to me and they say, so what's restorative and what's maintenance? Every time. And so it's sort of, you know, it's a little, all these things are a little nebulous, a little unclear as a fairly new program director. 2 years now, but I still understand, you know, that we really need some good training, baseline, somewhere to go as a program director to know, to make sure that everybody's reporting consistently. I know that we are not reporting the same way that other places are.
Well, let's go to training on this list and see if there's anything here that
You know, Denise, to that point, I think separately billable services, we spent hundreds and thousands of hours training on that. I bet you there's some definitions in there we could look at. That was before your time. Lucky you.
But what you're, I think, describing is maintenance therapies in adult day healthcare CBAS. I mean, that's defined one way. The therapists, I think, are asking a different question. And so one of the things I think we really need to look at that terminology. And if we have something that means something in our regs or our SOPs, that has to be strictly defined. Because I'm seeing this quite a bit, even requirements come through where I'm trying to assess even does this apply to our facility. But there is no definition given, and I go looking and I can't find a definition that will allow me to see whether it applies to our.
I hear you. On this particular one, I'd say it does track exactly back to separately billable services.
We've got
how we have it
background.
How we have it defined in the Medi-Cal manual. So when your therapists are wondering what goes in that participant characteristics report for restorative therapies, it's going to go directly back to what's in box 22 or whatever on the IPC. So if the PT put it in his or her box, it goes in the person who carries it.
Right.
But that's
Apparently
something
what I'm saying is, like my occupational therapist works in other worlds as well.
Yeah. Right. Oh yeah.
So they
definitely.
will not see it in that same way.
Yeah, they don't see it, and the OTs have actually a real grievance with us. We've dealt with the board before about our maintenance program, but. Can I, because I really don't want to run out of time and I want to get all these ideas up here. But yeah, placeholder for that thought. So under the category of improving training and competencies, these are ideas that we kicked around for a while internally and with others. We have 2 items identified here that validate, and by validate it would be CDA, validate all required training of center staff. So right now I can tell you it has not been a big focus area for us. We're trying to make that shift and trying to think about tools that we're going to develop to make sure that minimum training that's established in laws and regs is met. So, for example, CDA can develop training certification form. So basically, that we give to the providers, let's just say at certification renewal or annually or something, that shows minimum required training for all center staff. Providers would have completed the time of cert renewal, document that mandated training is complete within the required timeframes for all center staff. Okay, so that's a really basic one. It ties right back to compliance with program requirements. Well, no, Ruth left again. This was the one I wanted to hear. Okay, so number 2, number 2 here was adopt standardized approach / courses for specialized non-mandated training that centers could voluntarily complete. So this would be one of those additional points for centers going above and beyond. So course curricula could be developed by the Quality Assurance Advisory Committee that we're proposing we establish, and might include things like administrative program director leadership training. Min, you brought that up if you're still out there on the webinar. Training in person-centered care, training in cultural competency, and we just threw a bunch of ideas out here. Training in how to administer specific screening tools, and advanced courses for certifying competency in meeting the needs of specialty populations such as those with Alzheimer's disease. So again, I mean, this is a path to talk about. There's basic training that's required for everybody, and you have to, as a provider, make sure all your staff are prepared with those basic things. And then there's that additional stuff that some of you all, who participate in additional training opportunities and go to CADS conferences and do workshops, etc. You guys educate your staff and yourselves, and you keep moving in your learning organizations, etc. Where is that getting any credit? You guys get extra credit. There's no extra credit for that. But it does, I think, predict better outcomes. What do you guys think?
We have that on our list.
Yes.
That was one of our items. We haven't tested yet, but it was on our list for
Right.
quality indicators.
Right. So if there were sort of a list of sort of things that centers could do to get some kind of a standardized, set of educational opportunities, and they could say, yes, our program director and administrator have completed this leadership training. Our clinical staff have completed person-centered care, and we could identify that and capture that.
So we've trained and then Orange County just did a training with Easter SEALs that Cal Optima helped facilitate. We've trained over about 203 people have gone through person-centered care training just through CADS support. Then there was additional training at Orange County recently. Then one example of this would be we have a medication reconciliation protocol that came out of our CBHH project. So we have given people certificates for having gone through that protocol training.
Right.
So that's like one concrete example where somebody could then say, I've gone through this training, I follow this protocol, we're implementing it, we're great.
That's what we're talking about.
Yeah, yes, that's an example.
And I think especially important, and we've heard this for many, many years about program directors and administrators, that there's no, in ADHC, CBAS, there's no minimum certification for those positions, and they're critical positions. So,
and that's one of the things on that impact data set is reconciliation.
Yeah, great. Okay, so it doesn't sound like there's any controversy to that. You didn't hear it all, Ruth, but that's okay.
Sorry.
No, it's okay. So again, we're talking about the minimum set of training that's required by laws and regs for the providers, and then centers that go above that and take non-mandated training on a voluntary basis, including things like in specialty populations.
Oh, great. Thank you. Let me apologize. My mother-in-law's being transitioned right now from hospital to a nursing home. So it's a social worker.
Sorry, no, that's,
I apologize.
do this, yeah, we're happy you're here.
And
Okay.
I would just suggest giving it the format like on the required training, give it out 2 years before the recertification.
Yeah. And Diane, I totally agree with that. I think of it as sort of being as like a job aid as well as a sort of self-attestation sort of tool, and we want to teach to the test. If it's a mystery to you what the requirements are, then you should be telling them. Yeah.
I like
Okay.
to do Alzheimer's disease. I appreciate it.
Yeah. We've been hearing you, Ruth. All your trips to Sacramento are worthwhile. And I would add that we put their advanced courses for certain members. So in other words, not just the minimum that is actually required by the law and the waiver and the regs that says that you have to be trained in the populations you're serving, but I'm talking about sort of the beyond that. What is the Alzheimer's Association sort of recommended curricula for serving, you know what I mean? It's that level that we're talking about. Okay, so then promotion of evidence-based programs and best practices. Again, some more ideas. Develop participant caregiver satisfaction survey that centers can voluntarily adopt. Okay, so that's a clear, that's actually, you know, when I went back and I looked through our regulations, I found that we're actually required to do participant satisfaction. As long as I've been here, we've never done it. So that's one of the major.
We have one of those tools.
I mean, we do it as part of our reviews when we interview our participants as part of our sample, but there's no comprehensive look at that. So I think that this idea has great merit and fits perfectly within all of the other required efforts. Number 2, identify centers that assist participants, caregivers in completing physician orders for life-sustaining treatment, the POLST, as a best practice.
Even an advanced directive would be good.
Okay, so not just POLST. Okay.
They're different, yeah.
Could you like that?
Very different.
Okay.
So I'd say advanced.
So anything in that area?
Yeah,
Okay.
I wouldn't limit it to just POLST.
Okay.
Hospitals want that.
Okay.
Yeah, it's really.
Yeah.
Okay. I thought that was sort of the gold standard now. No?
It's for a certain subset of people who would fall under the advanced directive.
Right.
We
Okay.
should all have advanced directives. Not everyone needs a POLST.
Okay, got it. Okay.
That's how it is.
My ignorance on that one.
And a POLST is
Okay,
a kind
number
of
3.
advanced
It's a more
It's a
detailed
subset
one.
of advanced
Number 3, again, another sort of reach for some things that might be easily within our grasp. Identifying centers that have systems for quality performance improvements in place that go beyond the Title 22 requirements. So we have really, really minimal requirements for a quarterly review UR committee that has to be made up of at least 3 members, blah, blah, blah. At any rate, UR committee and process in place for assessing of appropriateness of care, identifying areas and strategies for quality performance and improvement. So as a best practice, again, centers that have actual quality improvement programs in place in their center that exceed the requirements.
And we're working on a policy manual for quality improvement as part of our work group. So it's not ready for prime time, but it's getting there.
Yeah, none of this is ready for prime time. We're like I said, we're just throwing a whole bunch of these out.
I'm just letting you know we're ahead of you there.
Yeah, I know you're ahead of us. I'm trying to get you caught up here. Okay, I was starting to steal all your best ideas. Yeah. Like they're ours. Yeah. Okay, so. Number 4, establish criteria for best practice in person-centered care, use of specific tools, completion of training, implementation of program components, etc., and identify centers meeting them. So it kind of overlaps with tools in other areas, but again, identifying those centers that have done that. Okay, so I think that's the entire laundry list. So just want to remind everybody that this is not the last opportunity to talk about this. This is the first opportunity where we've sort of thrown these things out, and I'm sure that there are things that aren't on this list that we're going to see later that either we already have in play or are things that we think we can do. Definitely training and all sorts of other training opportunities to leverage training opportunities with CADs, with the managed care plans is on our agenda. CBA is going to participate in a training with LA Care in April. We just got invited to that to help them with talking about incident reporting and discharge plan, discharge reporting. So we know that there are more opportunities for training out there, but these are sort of the basic sort of things that we've been talking about and that we have on right now. So we'll send this out to everybody in between meetings and let you give us your feedback, then compile more feedback, because the direction we're going is getting this thing through the funnel and having us agree. Again, everything that we put in the plan doesn't actually have to be implemented immediately, and it could be a menu of things that we might be doing, to implement this quality strategy, and we don't make firm commitments to some of them, but we use a good subset of ideas. Yeah, Ruth.
This is just only because I know it's happening. But on number 4, where you say talk about criteria for best practices in person-centered care, for instance, like specific things. I wondered if we wanted to include something about or serving diverse populations, because that's happening in some ways, unless you've captured it in some other area. Because my thought is if you're serving, you have Spanish-speaking people and you're serving Latinos or you're serving Russian people as part of your program or another program, and I'm wondering if that falls in there.
Can we go back up to training, Jill, under number, the second one? Because I think, and we'll see
if it's encompassed.
Okay, so I'm not sure if we got it there when we said
be there.
cultural training and cultural competency.
Okay.
Is that what you mean, or do you mean something in addition?
Actually, I was thinking, because you're talking about evidence-based programs and best practices.
Okay.
And I think that there are programs out there right now that could have huge merit just because they've made it a point to focus on a specific population that is not being served well in other places.
Okay.
And I don't say this as to make it harder for you. I'm just thinking that might be one of the criteria.
Yeah.
You may not want to include it there, but I just want to put it out there because I do think that that's a growing area of need.
Okay. So it would actually be separate from person-centered care if I'm hearing you, and you're really talking about identifying programs that are serving difficult populations or
difficult or diverse.
Diverse
Populations. I was actually thinking diverse as opposed to difficult.
Yeah, difficult is a bad word.
So establishing criteria for best practices in serving diverse.
Like diverse or right. Diverse communities.
Okay.
Or some
and we can flesh that out further as we
specific.
Well,
specific as opposed to
to have carved out sort of the need to serve a specific population and are doing it well and are probably developing best practices.
Right.
Even though there may not be a measure for it very well.
Right.
Does that make sense?
Yeah, it does, and I'm also trying to wrap my mind around that.
Do you even want to put it in there? Maybe it's not something.
We'll put it in there as a placeholder, and I think that we'll talk about it. I think that, again, my hope is that we can draft a few of you to continue this in this advisory capacity, and that we flesh things like this out, and that if there is, that we name them like Lois and say, what are those specific populations that we want to sort of give the extra credit for or something, because if we just say diverse populations, everybody gets them. Say yes. Yeah.
Right, because there's a lot. That's
right.
There's not really.
The diverse cultural populations kind of falls into the person-centered thinking, right?
Okay, that's it. Yeah. Okay. So care that's
the fact that you develop strategies for diverse type of cultural or different population is
culture is built in.
Yeah, it's built into the person-centered thinking mentality.
Mm-hmm. And I guess I was thinking more in terms of, so I'll just use an example. So in San Jose area, there are a couple of adult day programs that speak totally Spanish, and that's totally great. I don't know if any that speak Farsi. And yet we have huge pockets of those populations that are growing older and developing all kinds of senior issues. So if I were an adult day program and I carved out a program to serve this population as well as whoever else I'm serving in a special way, could we not recognize that that's a unique carve out and they're doing it well and in a way that might provide a model for other people?
Yeah.
So again, I don't want to create avenues that don't exist, but I thought there might be avenues for creative thinking in serving people that we haven't.
Yeah.
I think personally it already exists.
It could.
I think it's dictated by the area that centers are in, and then it's dictated by population that centers do have. There are centers that have Latino and Filipino speaking, and some Chinese mixed, and some American, English speaking. So I think it's very diverse and it's already
Was it good?
So I
doing
think
a good job.
maybe it goes to this. Remember, Lydia, when you guys used to do, or maybe you still do, all the like quality awards and leadership awards.
We're going to bring it back.
Yeah, where we recognize programs that are being developed, like program components within a center, or programs that are doing something that's really excellent, exemplary. I think it's on the theme of promoting best practices, so that we highlight it, so that others can replicate it, or that we acknowledge it. Yep.
I had a slightly different, of course, take on thinking about this, because best practices in person-centered care feels to me like it has the potential to drive things in a particular direction and lose some of the importance of diversity. So I was wondering about in person-centered care for serving diverse populations, and just putting it explicitly in there, kind of as I think Ruth is suggesting, because what that says is really this is not going to be a single tool to address the needs of people across many different cultural backgrounds.
Right. So can you think of a way that we can capture that here, so that we can
establish criteria for best practices in person-centered care for serving diverse populations?
For serving specifically.
So that we actually link them together there.
Okay.
So that it doesn't start with just looking at person-centered care. It makes sure that diversity is at the forefront of our efforts in person-centered care.
Got it. Okay.
Because it could mean diverse within your center. You have huge diversity, or it could be diverse in terms of like specific populations.
Right.
So
which, when it comes to person-centered care, I would just guess from an operational point of view is where the real difficulty lies. If you're trying to be person-centered with Alzheimer's, TBI, mental health, DD. Wow. You think it's not hard?
No, I don't know. It's hard. Person-centered is hard.
Yeah.
To do the way Beth and Lynn teach it, especially, but I think it actually is conducive to diversity.
Yeah. Okay.
Yeah, but it's hard, and it's ongoing.
All right.
Can I ask a quick question? Maybe DHCS could go back and ask their colleagues. I'm wondering if anyone there is tracking the whole CMS impact process and the 10-year plan for getting data across all the provider communities, from hospitals to home and community, and interoperability of data, and it's a 10-year plan. I just was on a webinar about that. It was blowing my mind. And I think that there must be, because it's a mandate. Because I'm trying to figure out how we link some of these things together. I was saying with Denise, we can have great ideas and start going down this path, but the whole rest of the system is going up here. And since we are not on anyone's radar screen at the federal level, other than home and community-based settings regulations, we're just like a little footnote, home and community. But we're in healthcare, so it would be interesting to find out if there's somebody at DHCS that's kind of the point person on that, and be sure we link up with.
Yeah. And Lydia, I was noting at the top of this discussion that we didn't venture too far into things like the health outcomes. We're really, this list that we just reviewed is primarily about provider preparedness, competencies, so it's really on the provider side of the equation and not on the participant outcome. I mean, obviously we believe that it leads to it, but we didn't go too far in that, and I think again, because this is the thing that we're most comfortable with here, this is what we do, is work with the providers. So I also just think that we're going to try to take the cue from you guys that we're going to take a modest approach, because so many other things are happening at the national level and at the state level.
Yeah.
And then we don't know what those participant health measures are going to be just yet. Some of them we do.
Yeah, and I think you're taking the right approach, because getting evidence-based practices, which are proven practices, aligned, rather than starting. We can't start out here. We have to start by operating in accordance with it, and then look to see what's happening with you.
I was sharing with Lynn too that I read in the Sunday Times this last weekend a piece about how economists look at presidents and how like the wrong lens to look at them through, because we look at whether they do well with the economy, and that so many things are just out of their control, and so many things have delayed effects. And so somebody like Bill Clinton can inherit a great economic set of circumstances and have a great ride and be thought of a certain way, and then the economy takes a dump, and then George Bush gets, so whatever your political views are on the subject aside, that this idea that what you do in a CBAS center is not necessarily, despite your best efforts in your community-based health home project, that you're serving super utilizers and are going to end up in the emergency department, despite your best efforts. And so there are these things that get really, really sticky with tracking participant outcomes, that you may be doing extraordinary work, and yet it doesn't change the ultimate effect of participants' decline or. Anyways, it's complicated, so I guess that's my way of saying that I try to stay away from it, and I'll take my cues from other sources to see what we want to include in the way of health measures. But we know how to talk about what's best practice and some good predictors of provider success. Okay, all right then. Okay, so let's bring this thing home. So to summarize this document, we're going to put together, whether it's in the original work tool, and we break these things out and we put them in their categories under those three waiver requirements for assuring health and safety and person-centered planning and licensing and certification requirements, whether we do that or whether we just give you this list that's recycled and dusted off. Probably stick with that. I'm already getting the cue across the room. But we want to make sure that we give you guys ample opportunity to give us feedback before we gather again in April, because we've got to start bringing this thing into a format. And so we'll clean it up, circulate it, get all of your feedback, and get the conversation going for the meeting for next time, where we can continue to hone in on what we're going to embrace, what we think is doable. And again, remember, 5-year plan. Yep. With a modest start. Okay, so that's the closing thoughts there. Anybody online? I see some comments. Do we have anything we need to share from the webinar?
Min had just written in talking about, I think this is a few minutes ago, she was talking about communication related to language and health-related deficits, adding something not only related to culture, but how to communicate to people who speak different languages, or maybe deaf, blind, or have any other deficits, in order for them to receive the right information in terms of quality of care.
Okay. So, anything else?
No.
Anybody else want to raise your voice on any subject that we've just covered? Or anything else?
Daisy had chimed in just earlier regarding the POLST and Advance Directive discussion, okay. Just to say she may suggest to keep POLST in the list. POLST is the form the 911 would seek for when a participant is no code. So I guess maybe it's so.
So Advance Directives and or life-sustaining, the POLST.
That's it.
Okay. All right then. Let's see what we have in the way of action items to keep ourselves honest and moving forward. What do we have? Does anybody have anything? Please, call them out, Lynn. Thank you.
Okay, so we're going to follow up in June what data is reported on the HEDIS measures related to plans and CBAS participants. And you can let us know if there's anything we should do in between now and when that data comes in.
I'd like to see the report or something that you had referenced, your work with the plan that you guys.
Yeah, we'll set up a phone conversation. I'll have Russ in on that too.
Okay. Good. I don't know what, if these are action items per se, but just things that we're going to be tracking in terms of training, the idea of CD staff not only going out to centers for monitoring visits, but the concept of training. I mean, that's
right, training through the right line. Yeah.
The regulatory reform, there's an inconsistency in the regulations and making decisions about, regulatory reform activity. Updating the CBAS website related to the CBAS ADHD program description, making it more user-friendly, consumer-friendly. Diane volunteers to work on that with
To react.
The request to extend the submission date for, was it the PCR that we were talking about?
Yeah, we'll look at the
Okay,
dates.
so we will, take that into consideration. We need to focus on definitions of terms, for example, related to maintenance or restorative therapies and others. We'll make the
Actually, can you just note that as an IPC crossover discussion, because we're going to talk about the definitions that go along with the IPC.
Yeah, good idea. We'll make the, edits based on conversation with the existing initiatives document, like advanced directives and polls. I'm sure there'll be more discussion around that related to the IPC.
And we'll route it for comments between meetings.
Yeah. We will distribute this, the quality, I don't know what we're not calling this the framework, but it's the strategy outline to everyone to provide their input on what we've just discussed with this work tool. And Oksana, I think there was a request that you would see what DHCS is doing related to the impact mandate. Is that the question, Lydia?
Yeah, it sounds like it's not that critical right now because I think that is more focused on health outcomes, which this group isn't really going to be addressing. But if that's just an easy ask somewhere and you could just connect them with me, I just would be curious what's going on. Because we are improving the health outcomes for our work. So I'm just emailing you. So.
So that's everything on your list? Did you have anything else, Eden, that was on your list?
No, the only other one that I have was comparing ranking scales of other departments and agencies' ranking systems.
Okay.
What was that? I couldn't. Oh, I'm sorry.
I was kind of taking notes along the, I don't know if they're actual action items per se, but the only other note that I have different from yours is that we take our internal ranking scale and kind of compare it to other departments to ensure that we're all ranking according to similar factors.
All right. Anybody else have anything else that we said that we were going to do that you want to remind us that we said we were going to do? Can we stay committed to it? Stay on track? Anything else? Okay then, what's next on our agenda? The only other thing we have to do, we identified that one issue as an overlapping IPC issue, and that has to do with definitions that we talked about. Lou, was there anything else you wanted to address with regards to the separately billing?
No, I think we just should review our instructions in there for the maintenance versus therapy, because that'd just be good to remind everybody with that. Or maybe we should review it, see if it's still relevant. Definitions of maintenance and skilled, because we spent a lot of time working on that.
Okay. Okay.
So I think there's some good guidance in there.
Okay. Yeah, I think you're right. So we'll touch on that.
Yeah,
we'll touch on that a little bit today in the next work group. Okay. Any other overlapping issues that we need to make sure that we communicate with the next group that's coming in? Take a look at it. Okay, then the next task that we have is we're going to try to get away from too much survey monkey, do and poll, whatever it is that we've been doing lately to get these meetings set. It's very difficult to get these, to just figure out who's going to be available during different meetings, so April 5 and 6 is what we've identified for an April meeting. So just sort of as a preliminary, yes, Lois.
That is spring break for lots of schools.
Okay.
I know it's
all right.
My child's school is that
okay.
week, so it's not a good week for me.
Okay. And I will just say that because it's just so much preferred that we work with people in person. It's so difficult, as you see via the webinar. We want to invite people and give them the option to do that, but we want to get as many people in the room as possible, so we definitely give weight to the meeting dates for the people who are attending in person. So, okay, so that's, so do you have another suggestion? And I think the following week we're doing a CADS training that we're going to participate in. So some of us are going to be offline for that.
I know I have some challenges getting this room.
Okay.
Or getting a room in April, so I think that's why. And we didn't go the second week because of the CADS training.
Okay.
But I can look at the third week of
okay.
June.
2 days or
April.
1 day?
It's just one day. We're just trying to give you some options. So is April 4 or 5 completely out of the question for those?
5 or 6.
Okay.
5 or 6.
Out of the question.
It's out of the question for Ruth, and she's one of our tenders. And it's out of the question for Lois, and she's been here every time too. So.
And we're going to be preparing for that training. So.
Yeah.
Okay.
Yeah. So. Okay.
I'll look at the 3rd week,
All right.
which would be.
Or maybe we bump it up and put it in the end of March. I don't know. I mean, I suppose we could consider that. We just picked April because we're trying to space these 2 months apart, but this isn't science.
Well, I'll look at April 19th and 20th, and I know, can we talk about Tuesdays versus Wednesdays? Tuesdays is hard, I know for Lydia, you have the NAD stuff.
Our HCB, we have standing meetings on Tuesday afternoon with CBHH, so that's myself. It's quite a few other people, Diane, Dawn, Celine.
Yeah, and Celine has some standing Wednesday meetings.
Oh.
So I don't know. Yeah, this is the complication.
Yeah, this is the complication. Yeah, it really is.
Please don't be angry if
Yeah.
you pick a date that you say.
Yeah, well, and I think that this next round, because we're not going to settle this today, we're going to do the same thing with the IPC group this afternoon, is I think that what we need to do maybe in our next doodle and poll is to have people identify whether they're planning on attending in person, because we really need to be more scientific about scheduling the meeting around the people who are going to be here in person.
Yeah, and Doodle doesn't seem to, at least I haven't figured out how to get additional data, so we'll figure out some way to find out more, just whether you can attend on certain dates or not.
Got it.
You could do a survey monkey.
Yeah, we would.
Can you do a note down at the bottom on Doodle? I was thinking
There
that.
are, yes.
Yes.
Thank you, Diane.
Okay, so we'll work on that. How about the June dates? Do 14 or 22, do either of those preclude anybody in the room's participation?
14 is Tuesday, 22nd Wednesday.
The times stay the same, correct?
Yeah, so we're doing, for consistency, we're doing quality in the morning and IPC in the afternoon, yeah. That was too many moving parts. We already learned that in the first meeting.
Well, so you already know that our Tuesday issue.
Yeah, so we may have to look at some other day of the week. Mondays versus Fridays. Thursdays we usually have state transition plan calls.
We'll get a hall pass on that one. We got to finish.
Thursdays.
Are Thursdays precluding anybody's participation? Okay. Yeah, let's look at some Thursday options. Okay. Well, this has been clarifying as mine. Is there anything else I want to throw into the regarding the scheduling? Yeah, so just be patient with us because I know we've sent you a lot of emails and trying to, figure this thing out. So we do the best we can to get most of you in the room to do this. All right, so we are going to have lunch come into the room for those people who ordered it and are sticking around, and we'll visit and commit and talk about what we just talked about and anything else we want to do. You can go out and take a walk, get something downstairs if you didn't bring a lunch, or order one, and then we'll get ready for starting the next meeting at 1:30. And we're going to go offline with the webinar for the people who are on the webinar. We're going to turn it off, and then we'll restart it for the 1:30 afternoon meeting. So you'll have to sign back on if you're hanging out for both meetings. Is there anybody online who has anything further to share with us? I wish we could get you to talk.
It's hard on
Anything? It is. Really
we are following patiently.
Great, thank you, Burge. I appreciate you lending your voice to things. Anybody else?
Talk to you guys at 1:30. Bye.
Okay, thank you. Yeah, it's a really important effort. I hope you guys feel like that. We have a really great opportunity here with putting this together, and so really appreciate all of your participation. It's super important that you're here. So thank you very much. Okay, so we're offline until 1:30. So ended a little bit early, actually. Okay.
Lunches were to be delivered. So
Yeah, I told Nolan not to bring them in and disturb us when they came. So I'm sure they're here.
Okay.